There are polyps that are very subtle. And in my mind, there's a specific polyp that's called sessile-serrated adenoma. To me, is like a beast. And you have to be in the mentality of, I want to find and hunt that beast. Because they're very easy to miss. And at the same time, they're also probably more dangerous than other polyps.
So I'm here today with Dr. Toufic Kachaamy, who is a gastroenterologist at CTCA, at Cancer Treatment Centers of America here in Phoenix. I work with him on a daily basis. We've been working together for probably like 5 years now. One of my favorite people, and I'm glad you're here. So welcome to the show, and let's start off by talking about your background. Where are you from? Where did you train? So forth.
Thank you for having me today. And I'm originally from Lebanon, and I've been in the United States for over 16 years. I did my medical school at the American University of Beirut. So it was American training from the beginning. And then came and did my internal medicine residency at Duke University. And then specialized in gastroenterology at the Medical College of Virginia. And then did advanced endoscopy training at the Mayo Clinic in Arizona.
And somewhere in there, though, didn't you practice medicine in underserved
I did.
area?
So when I came, I was on what they call an exchange visa. And then to be able to become American, I practiced for 5 years in a medically underserved area.
Where was that?
This was in Waterloo and Cedar Falls, Iowa.
Okay, and when exactly did that occur?
After my internal medicine training. So I did 5 years of general medicine practice. Yeah, I had a great time. It was a great experience. And I love the people of Iowa.
And so since you finished your fellowship in advanced endoscopy, that was at the Mayo Clinic here in Phoenix?
Correct.
So your first job after that was at CTCA?
Correct.
Right, and so you deal with cancer patients day in, day out?
Yes.
And so, we had talked about what we wanted to discuss today, and we came up with the topic of screening for colon cancer.
Yes.
Which is, I think, a great topic because it applies to everyone, right?
Correct. It applies to everyone, and it's very relevant, I think, to what's happening now in terms of cancer care, preventing cancer, and there's a lot of options now that are available that were not available a long time ago.
So why is it important to get screened for colon cancer?
Because it is almost completely preventable. And if you look at other nations and you compare them to the United States, the colon cancer is on the decline in the United States versus in many other countries, even advanced countries, it's not necessarily on the decline.
And the reason for that is the screening, or is it other factors like diet and so forth?
It's partially screening.
Okay.
And people with colon cancer are living longer, and partially is because we have better treatment for colon cancer. So diet plays a role into it, but the role of diet in terms of preventing cancer is very difficult to define because all the studies that were done on this are broad, what we call epidemiologic studies, which are not very controlled studies. So it's really difficult to tease out factors. We know that screening plays at least a big role in the decreasing death from colon cancer and in decreasing colon cancer in general.
Okay, so when you say it's almost completely preventable, that means it's different from other types of cancers, right? That pancreatic cancer,
yes.
That kind of thing. Meaning
yes.
You can go to the doctor as a healthy patient, get the screening test, some sort of screening test, and either catch the cancer early or just prevent it altogether.
Correct. Now, almost completely because we still have work to do to basically prevent it completely.
So almost is a key word.
Yeah, almost is a key word. And this is why someone who had screening and the screening is negative, if they have symptoms, they should not ignore it because they had the test that was negative.
Okay.
So you have to keep in mind there's no perfect test yet.
So what are we looking for during these screening tests?
We're looking for the precursor for cancer. And this is why colon cancer is really the prime cancer for screening. because you have precursors that are called polyps, and these polyps are growth that grow into the colon, and most of them are benign, but some of them turn into cancer. What's nice about the polyps is they present the perfect opportunity for screening. So in general, when you talk about screening, you want to have a test that's acceptable. You want to have a test that you could afford doing for the population. You want to have a test where if you find something, you have treatment for it. And you want to be able to apply it to patients in a way where it's acceptable to them. And
so when you say acceptable, you mean they're just willing to do it. It's
willing,
not scary. It's not,
It's not scary. It's not dangerous.
Painful.
So it is acceptable. It can be defined in many ways. One, people can afford it. Two, they like for example, if you want to do a screening colonoscopy, you have to take a day off of work, and also a caregiver has to take a day off of work. So for some people that's a barrier, and you have to take a day off of work during work week. So for some people that's a barrier, and that might make screening colonoscopy not acceptable, but they have other alternatives that they can use for screening. And this is why the test has to be acceptable. The only good test is the test that's done.
The only good test is a test that's actually done.
That's actually done. Because you could have all sorts of modalities that are available to people now, but if they're not being used, then they're useless.
Right. And so why, so you were talking about how colon cancer screening is almost like the ideal.
The ideal because we have that precursor target that you could screen for, find it, remove it effectively and safely in most cases, and completely prevent cancer. So we're changing the demographics of cancer. When I say colon cancer in the United States is on the decline, partly because we are screening and we are preventing, we are changing the natural history of these polyps and the natural history of cancer because we have this target to remove them. If you want to compare it, for example, to pancreatic cancer, we don't have a target that we can identify now that comes before pancreatic cancer. So we're limited at diagnosing it after you have the cancer. So
the polyp is a precursor to the actual cancer, right? Or it can turn into cancer.
Correct.
Right? And how long does it take?
So there are different types of polyps. There are polyps, for example, called hyperplastic in a certain location in the colon that we think almost never turn into cancer. There are polyps that are called adenomas, and these are we think the most common source of cancer.
Okay.
And on average, from a small polyp to cancer is probably over 10 years. And this is why it presents a very good target because you have time to find it, you have time to treat it and remove it, and it's not a test that you have to do every 2 weeks to find the cancer. So if you have something that's sitting there for 10 years before it turns into cancer, it gives you this perfect opportunity to find it. Now there are other cancers that can turn into, there are other polyps that can turn into cancer faster. And if you want, we can talk a little bit more about them. And we're learning how to find these now. And also it depends on risk factors. So there are people who have a genetic predisposition to cancer where they can develop polyps faster. And these people we screen more often. And also their polyps turn from polyp to cancer faster, so they have to get screening more often than the general population.
Sure. All right, so you used the term just now, you're changing the natural history of colon cancer, right? So what does the natural history mean? So
the natural history of, you can take it back to the polyps. So the natural history starts with a polyp, and that polyp grows slowly over time. At one point, it accumulates enough damage to the DNA, which is the code really for the genes. And then it turns into what we call an advanced polyp. An advanced polyp is one that turns faster into cancer. And then it turns into cancer, and then that cancer grows. And at one point, that cancer accumulates enough genetic change, it starts spreading. And once it spreads, then it tends to kill people.
So the term natural history, though, it means like what is the natural course of some disease, right? So for example, when I get a cold,
Yes.
it's got its natural history,
Yes.
right? So for me, day one, I'll wake up with a sore throat. Day two, I start sneezing. Day three, I stop sneezing but get a cough. And that day 4 through 10, I continue with the cough till it goes away. So that's like the natural
Yes.
history of my cold.
Yes.
And so so the goal of all of medicine is to improve upon that natural history, right?
Yes.
So the natural history of polyps is to eventually, or at least some of them, turn into cancer and then metastasize through these changes and so forth to
Yes.
other parts of the body. And we have the hope that we have the ability to cut that natural history short,
Yes.
right?
So, I mean, if you plot, how many cancers people were getting, and look at the time where screening was introduced, and look how long people were living, you notice that the curve has changed. From curve going like this, it started going this way and maybe coming down. And that, to me, is a change in the natural history. And I don't want to give screening as the only reason for people surviving longer with colon cancer. Treatment is also better now than it used to be. So, but yes, as healthcare professional, our goal is to improve quality of life, have people live longer and enjoy life longer. And I think screening for colon cancer does that.
Yeah.
And in many ways, one is if it prevents cancer completely by removing it at the polyp stage, then you never get cancer. If it finds cancer early before it spreads, then you're a lot easier to be cured.
Yep.
And basically, once you find it when it's causing symptoms, and especially symptoms elsewhere in the body than your colon, then you missed on that big opportunity to improve on your health and also save on the cost of taking care of this problem. And that's where I feel that we're making a big change. And as similar to everything else in medicine or that involves a living being, as we are changing the natural history, things are changing on the cancer end. So, for example, we screen patients at the age of 50, which is what's commonly accepted. So we notice that after the age of 50, colon cancer mortality is on the decline. It's rising before the age of 50 because we don't screen before the age of 50. So in that age category, when we diagnose someone, it is still, we are diagnosing them in their natural history,
Sure.
basically.
Oh. So what is the most common form of colon cancer screening?
So in the United States, the most common form is colonoscopy.
Okay.
And there are other ways also to screen for it, like checking your stool for tests. There's also something called virtual colonoscopy, and something on the becoming more available is a capsule colonoscopy, where you swallow a camera and takes pictures of the colon. So there are many ways to screen. They all have pluses and minuses. In the United States, colonoscopy up till now continues to be the preferred method in many centers for colon cancer screening.
And when was colonoscopy developed?
Around 30 to 40 years.
Okay, so we have a lot of experience with.
We have a lot of experience
Colonoscopy.
with colonoscopy. And it's actually interesting because a lot of what we know about the natural history of polyps comes from that era where 5 years before colonoscopy and then 5 years after colonoscopy. Because we had polyps that were being imaged and we were just looking at them, and then suddenly it became easier to remove them. So we had some data on how fast polyps grow, the distribution of polyps, and things like that from these polyps that we followed before colonoscopy, and then the polyps that we removed when colonoscopy became available.
Right.
Since then, all the polyps we find, we remove, so we don't have as much information on what would happen
Yeah.
if you leave the polyp.
Right. So what does colonoscopy involve?
Colonoscopy involves first taking a preparation to clean your colon. The colon has stool, and that makes it difficult to see what's in the colon. And the colon is a tube, and you want to empty that tube completely. So you go see the doctor, and then you get sedation because it can be an uncomfortable procedure. So some people most people are sedated, what we call moderate sedation, where it's like a twilight zone, so they might be responsive, they might follow commands, but most of them do not recall any of that procedure. And then we use a flexible tube that has a camera on the tip of it, and that tube is inserted through the rectum, and it gets all the way to the beginning of the colon.
Yeah.
And then once we do that, we inflate the colon and start looking
Inflate
for
full of
polyps.
air?
Full of air or CO2.
Okay, so it's a different gas.
It's a different gas.
Yeah.
CO2 is more comfortable, dissipates quicker, versus air, people will feel bloated and uncomfortable after a colonoscopy.
Yeah.
So CO2 allows you to inflate fully, because inflating fully allows you to see better.
So because it stretches out the wall of the colon.
It stretches out the wall.
So the colon's got a lot of folds.
it has a lot of folds.
So you could miss polyps if you don't look like behind a fold or whatever.
Correctly. And it's not very easy to look behind every fold. And this is one reason why we could be missing some polyps.
So just going back, you take the prep the day before.
You take the
Okay,
prep
so
the day
what is
before.
the prep? The prep is a liquid, right?
Yeah, most preps now are a liquid that are designed to be like a high volume wash of the colon. You also have to be on a special diet the day before.
Okay.
And then you take that liquid and it causes diarrhea.
Yeah, and so the liquid literally is just like a column of fluid that just pushes everything out.
Pushes everything out, and ideally you want what's coming out at the end to be clear, to be something you can see through it,
Yeah.
because that means that you got rid of all particles that would be difficult to remove during the procedure.
And a lot of people kind of dread the idea of the prep.
Yes.
Right, but why? If you had a patient saying, I don't know about the prep, why do I need to take the prep?
It's because it's probably the most important part in the patient preparing for the colonoscopy. You want the person who's doing your colonoscopy to spend the time looking for polyps. You don't want them to spend the time cleaning your colon, because that's time taken away from looking for polyps. At the same time, if they cannot completely clean your colon, it's a really a missed opportunity to find certain polyps.
Yeah.
So if you prepare yourself to the best of your ability, then you're going to have a better outcome from that screening test. Screening is not inexpensive, it's not risk-free,
Right.
so you don't want to have to repeat it because either you didn't follow instructions, or sometimes there are risk factors that are known. For example, if someone has severe constipation, then these people need more prep than someone who does not have severe
Yeah. So if the way I think of it, if you're gonna go through a colonoscopy, you might as well do it the right way.
Correct.
Right. So take the prep.
Yeah.
Right.
Otherwise, it's going to give you a false reassurance,
Yeah.
and that's not to your benefit.
Right. Because they could miss the polyps that are hiding in whatever's left behind.
Yes.
Yeah.
And I'll be happy to show you some examples of what
Sure.
I mean.
So okay, so the day of you show up at the center, wherever you're at, the hospital or the center where you're going to get the colonoscopy. They put an IV in.
They put an IV in.
The anesthesiologist talks to you.
Yes, in certain centers there's an anesthesiologist. In
Okay.
certain centers, the gastroenterologist herself or himself will administer sedation.
Administers sedation.
Either way, people will discuss with you the risks and the benefits, which sometimes is not the best time to discuss because you've already taken the prep. The ideal would be for you to get some description of the risks and the benefits ahead of time.
Ahead of time, sure.
And some centers provide that. They'll have a nurse, or you can have an interview with the person who's doing your colonoscopy so they can go over the risks and benefits. And sometimes, the referring doctor, so a primary care physician, can discuss these risks and benefits. But ideally, the person doing the procedure is the best person to discuss these details with the patient.
Sure. And then they'll wheel you into the room where they're going to do the procedure, start giving you the medications to sedate you.
Correct.
And most of the time you don't remember
anything.
the procedure at all, right?
And especially if an anesthesiologist is administering sedation, they can use heavier medications
Yep.
that will make it less likely that you're also going to remember.
Right. And then after the procedure, they wheel you out,
And usually you have a printout of your procedure with pictures, and then they give you the results. And sometimes when they remove polyps, they have to send them for analysis.
Yeah. So you, as the physician performing the colonoscopy, right, you put a flexible tube with a camera at the end into the colon, and what are you looking for?
The first thing we're looking is the quality of the prep. If the quality of the prep is poor, then we abort the procedure.
Quality of the prep meaning, is there stuff in the way still?
Yeah,
is there stool left behind?
That is significant enough to prevent you from doing a good exam, because then you would be giving a false reassurance.
Yeah.
And you have to repeat it. So if the quality of the prep is poor, then you abort the procedure. And then if the quality of prep is what we call adequate, so you feel comfortable that you can give a decent exam, then you're looking for polyps.
Okay.
And polyps, most of the times, look like a mushroom.
Okay. And so a polyp is just like a growth of tissue, right? It's just like a little lump.
Correct. It's like, when you get a mole on your skin.
Okay.
So that mole is on what I call the internal skin, the inside of your colon.
Yep.
And that mole, most of the time, does not turn into cancer. But when you find a mole in the colon, you want to remove it just to prevent any of them turning into cancer.
So almost all polyps you remove, or is it all polyps you remove, or?
All polyps need to be removed. There's some controversy as to very small polyps as to whether they need to be removed. So a polyp less than 5 millimeters. But most of the people would remove all these polyps. And I believe the right thing to do is to remove the polyp, because rarely even the small polyps can harbor cancer. There's probably more controversy as to whether you need to analyze all these polyps. But as a gastroenterologist, we remove all the polyps. There are polyps that are giant that, in my opinion, do not need to be removed on the first session, because these tend to be riskier polyps to remove. They need more preparation for the patient, and they usually fall outside of the consent that you've told the patient. So when you say to the patient, the risk is so and so of removing polyps, you don't necessarily, unless you explain to them if there's a giant polyp, then you're going to address it at that session, and explain to them the risk would be the risk of removing giant polyps is different than removing medium to large polyps or small polyps.
But in general, you're basically going to remove most of the polyps you see, right?
Yes.
And so you have those polyps in a little bowl or whatever, right? So
Correct.
what do you do with those polyps?
So we send them for the pathologist, someone who will basically fix them and then cut them into pieces.
Okay.
and look at what are these polyps formed.
So they'll do all kinds of tests, right? They'll look at them under a microscope, they'll stain it,
Correct.
various other things to see if there's any cancer growing in there.
Yes, if there's any cancer, and also how advanced these polyps are. So what was the likelihood of these polyps turning into cancer? Because we use this information to risk stratify, so to determine when do you get your next screening test or your next colonoscopy.
So if they see that there's no cancer in there, but there's some suspicious cells or precursor cells, then you would tell the patient, hey, I think you're at a little higher risk than the average patient out there for developing colon cancer in the future.
Correct.
So let's get a colonoscopy a little earlier
Yes.
than the other patient.
Yeah. So after a colonoscopy, the interval for what we call surveillance, so when you get your next screening test, can be 3 years. In general, it can be 3 years, 5 years, or 10 years.
Okay.
And so this information is used to determine when is the next appropriate time for you to get.
So if a
screening.
patient has basically nothing suspicious found on the colonoscopy, the general recommendation for their next colonoscopy is
10 years later.
10 years.
Yes.
If they have findings that are a little more suspicious, it may be 5 years, and if they're even more suspicious,
Then it's
3
3
years.
years. Correct.
Okay.
Yeah.
Okay. And so you had mentioned that even cutting out the risk, the polyp has a risk, right? So just in general, what are the risks of undergoing a colonoscopy?
Yeah, so in general, because it involves sedation, so the risk of colonoscopy involves also the risk of sedation.
Okay.
So that's, risk number one.
So we're giving you drugs to sedate you, and that could slow down your heart or slow down your breathing, and that in itself has a small but non-zero risk.
Correct.
Right.
And also you can have some people have never had sedation before, so they could be allergic to certain medications, and you discover it in that procedure. So allergic reactions like you mentioned, slowing down the heart or slowing down the breathing. So that's in general Risk number one.
And that's the case with almost every medical procedure.
With every
that
medical
involves
procedure that
sedation,
requires
right?
sedation. Then the next would be the risk of missing things. And I make sure when I explain to patients who are undergoing colonoscopy that we have a risk of missing a polyp or missing cancer. Missing cancer would be unusual, but missing a polyp is not that unusual. So that's in my mind risk number one.
Okay.
That, patients need to understand if you have symptoms after colonoscopy, do not ignore them just because you had a colonoscopy before. And then you have the risk of inserting the flexible tube, which has a small risk of perforation.
You mean a tear?
A tear
of the actual colon.
of the actual colon.
Yeah.
And in most cases, that risk can be minimized by good techniques and being very careful. But you can never take down the risk to zero.
Okay.
And then comes the risk of removing a polyp. So the polyp is a live tissue. It has vessels that are feeding it. So the first risk would be bleeding when you remove a polyp.
So when you remove a polyp, how do you put a little lasso or something around it, right? And you,
Correct. And then you choke it. Sometimes it depends on the size. You can cut it without cautery, so without electric current that burns the tissue.
So the little lasso, you can press a button that makes the lasso really hot. Right?
Really hot,
and it burns away the stump, basically.
the
right?
stump,
Yeah.
and it burns the vessels that could be in the stump.
Right.
And then if you don't use cautery, then the risk of bleeding is usually evident immediately.
Okay.
But if you use cautery, then it takes a couple weeks for that area to heal, and you can bleed later also.
Okay. So cautery means burning, right?
Cautery
And
means burning.
burning it kind of seals the blood vessel, clots off the blood vessels generally
Correct.
right away, but you're saying it could bleed a little later.
It could bleed a little later.
Okay.
And also, when the polyp size is very large, sometimes you cannot cut it without burning the base.
Yeah.
So you would need to burn it, and that comes also
Yeah.
with a small risk. You could also damage the muscle under the surface. And if you damage that muscle during burning, then that's where you can have a delayed tear.
Yeah. And so, but what is the quantification? What is the risk? Like, how much is that risk?
The risk of bleeding is around, it depends on the size, it depends on a lot of characteristics, but probably in the 1% to 2% range.
Okay.
That's a general statement. And the risk of a tear is much lower than that.
Yeah.
Sometimes the tear is seen immediately when you remove a polyp, and it could be fixed immediately. But sometimes if it's related to burning, it can show up later, and then patients will come with symptoms.
Yeah.
In general, these are unusual.
Yeah.
And so we talked about the risk of bleeding, the risk of a tear, and these are, so missing things, bleeding, tear would be the most common
Yeah.
things in colonoscopy, or the most concerning things.
Sure. So you mentioned earlier that we can prevent almost all colon cancers through screening, but not all of them.
Correct.
And explain again why.
First reason why we do not prevent all cancer is not everyone is being screened.
Okay.
So that's reason number one, which is the obvious reason. If you don't get your screening test, you're not going to prevent your cancer. The second is there are limitations inherent to screening. So our tests are not perfect. Like, for example, we talked in colonoscopy that you could miss polyps. There are certain polyps that are obvious. You're going in, you're doing a procedure, and the polyp, just is calling you. But there are polyps that are very subtle. And in my mind, there's a specific polyp that's called sessile serrated adenoma. To me, is like a beast. And you have to be in the mentality of, I want to find and hunt that beast. Because they're very easy to miss. And at the same time, they're also probably more dangerous than other polyps.
Yeah.
Partly because they're difficult to find, but partly because their makeup makes them turn into cancer faster.
Yeah.
And also removing them is not as accurate as removing the obvious polyps. So you have to do a little more extra work. And so some limitations related to the test itself, like the stuff we're talking about. Now, some limitations related to some cancers do not necessarily come from polyps. Some cancers can occur quickly when something happens. So you could get the perfect test, and still, when you are done with the test, in the interval develop a cancer.
Yeah. So you mentioned the term interval. So you mean the period between one colonoscopy and the next. That's
Correct.
called the interval.
Yes.
And there's some cancers that arise in the interval, right?
Yes.
And we don't know why, or there's theories to why.
Yes, I mean, we have an idea as to why.
Okay.
Some of it has to do with technique. So if you have the colon that has folds and you don't look behind the folds, then you're more likely to miss them. And then these polyps that are missed can turn into cancer.
So in other words, they were there the first time.
They were there and they
but
were
because
missed.
of the limitation of the technique or whatever, you didn't find it.
Yes.
Okay, and it looks like it came about after the colonoscopy, but it was actually there
Correct.
the whole time.
Correct. And, you know, the technique is not just the technique of the person doing the procedure. There are limitations to colonoscopy by itself. Like if you, one way to look at the colon would be to flip your scope all the way, what we call retroflexion, and that allows you to see the other side of the fold.
Oh yeah.
So, you know, this is a technique that someone can do to minimize the miss rate. Another technique would be to wash very carefully all mucus and look very carefully. Another technique would be to look 2 times. So there are certain things you can do to minimize the risk rate. It's never going to be down to 0, but getting a good test improves your chance of really decreasing what we call these interval cancers.
Yeah. So it sounds like, I mean, decreasing these interval cancers is partly in the hands of the patient, meaning do the prep
Yes.
and follow the instructions and make sure your colon gets completely cleaned out, in which the patient has a lot of control over. Okay.
Yes.
Second part might be the person doing the colonoscopy,
Yes.
where they have to actually look very carefully around all the folds and make sure they're hunting that beast, as you said,
Yes.
right?
Yes.
But the third part might be, despite all that, there's some biology that we simply can't overcome, right?
Yes.
In other words, the colon cancer actually does arise in that interval, and it's the type that grows very quickly.
Yes.
And we, you know, despite everything we know and all of our efforts, bad things can happen.
Correct. And some of that also has to do with predisposition. So there are people predisposed to having cancer, but you might not know about them. They might not know. And these people need to be screened more often. But if
Yeah.
they don't know and they don't get screened as often, then they could develop the cancer quickly.
Yeah. So you brought some videos that
Yes.
we can show about how easy it is to miss some of these difficult polyps.
Yes.
And so let's look at those.
Yeah, let's look at those. The first video I want to show you is what we call a standard polyp.
Yeah.
And this polyp is called an adenoma, which is the most common type of polyp. So if you watch here on the screen, this is a polyp, you know, it looks like a mushroom. So this polyp is bulging into the lumen. And you can imagine that this polyp, when you look at the head of this polyp, it's completely different than the area around it. So they're easy to find, or easier to find. And then when you find them, your goal is to remove them completely, ideally in one piece, and remove them safely. Versus, I'm going to show you in this second video, you notice here that I am what we call the withdrawal phase. So where I got to the beginning of the colon, and then I'm pulling out, and I'm looking around. You know, you look around, up and down, right and left, and you notice here I stopped a little bit to examine more carefully.
Yeah.
And I don't know if you can tell that there's a polyp there, but there is a polyp there.
Very hard to tell.
Yeah, and I'm gonna after there's a maneuver that where we inject under the polyp dye to highlight the polyp. So here you can see I'm putting my needle out and I'm starting to inject and injecting more, and this is what we call lifting the polyp.
So that's the blue stuff that we're seeing.
That's the blue stuff that we are seeing. And when you inject that blue stuff completely around the polyp, like here, then you realize this little thing where we were not sure there's a polyp is turned out into this big polyp.
Right. And it looks even bigger
Yep.
than the original one.
Than the original one, partly because we made it bigger, but because it's flat, it's really bigger than you think. And when you expand it, it's really a big polyp. And this is why I call it a beast. It's a beast that's hiding behind a fold, usually hiding behind some mucus. And unless you're very careful, and even when you're very careful, you can imagine that this is not easy to find. Yeah. And when you're very careful, you have to remove it in the appropriate way to make sure all of it is removed. And what we think is this particular polyp turns into cancer faster than the other polyp that I showed you at the beginning. And this is one example as to why colonoscopy or other screening tests continue not to be perfect and why we are not preventing all colon cancer.
Okay. Yep. Very interesting. I can easily see how even a gastroenterologist with years and years of experience could miss that.
Absolutely. Yeah. And that's something that we always worry about after every colonoscopy.
All right. So you finish your colonoscopy, and what do you expect afterwards?
So first, in most cases, you should not have any symptoms before you leave. So you should be completely, feeling fine before you leave the recovery room. And then if you develop any new symptoms, you need to contact your doctor and let them know. The second is before you leave, they're going to give you a report which will have, their findings and what they did with the findings and what to expect. And probably the most important part is knowing how to read that report and what this information is going to give you. This report typically goes to your primary care physician also, so they will also help you read that report. But the things you want to look in the report, first is, was your preparation adequate? And there are scoring systems to determine that, and there are also general subjective assessment. But what you want to ask is, was my prep good? Was my prep adequate? And then they should tell you whether it was adequate or not. If it was not adequate, then most likely they're going to recommend that you repeat your prep, do something different, and get your procedure done again. But if your prep is adequate, did you have polyps? If your colonoscopy was completely normal, you want to look, was the entire colon examined? So the first thing is the cecum is the beginning of the colon. And
okay.
that term,
that's on the right lower part of your abdomen.
Right lower part of the abdomen. It's where the small bowel enter into the colon. So it is standard to take a picture of the cecum to document that we reached that area. So after the prep, you look, was the exam complete? So was the cecum reached? And if it was yes, we're supposed to take a picture to document that we reached it. And then if your exam was completely normal, no polyps were found, then if it was a colonoscopy, obviously you're good for 10 years in most cases, unless you have certain risk factors. And if polyps were found, you want to know how many and what were the sizes, because these determine what happens afterwards. And then when you leave, it takes usually a few days to a week or so to get your the analysis of the polyp back, which is the pathology report.
Pathology report, okay.
So in that pathology report, there are certain things you also should be looking for, and your doctor also should be looking for, whether your primary care physician or the gastroenterologist who did your procedure. And these were, in the pathology report, sometimes the size will be mentioned. Anything that's more than 1 centimeter is important, is what we call an advanced polyp. And also whether there was something called high-grade dysplasia. And basically it means this, the cells were funny looking and they were no longer looking like normal. So they had some changes in the cells that make them more likely to turn into cancer. So these are two important things to look for in your pathology report, where typically the pathologist will say there's no high-grade dysplasia. It means that polyp, if it's less than 1 centimeter, had a low chance of turning into cancer. Combined with your report and your pathology report, so your colonoscopy report and your pathology report, your primary care physician and or gastroenterologist will reach a determination as when you need to have your follow-up screening test. And these are the things really to watch for, because you did your screening, but then after your screening, you're going to be enrolled in a surveillance program. And that surveillance program is to continue on finding things before they turn into cancer or cancer early. So when you leave, you're not done until you know when you need to come back.
Yeah. And like we said before, that can either be 10 years, 5 years,
3 years,
or 3 years.
Or sometimes even 6 months.
Sometimes 6 months.
6 months. Okay. Or earlier. It depends on what they found. So if a large polyp that was not removed was found on the first colonoscopy, then they're gonna set up a convenient time for you to come back and have that removed.
Yeah. So what are the currently accepted guidelines for having these screening colonoscopies?
So the accepted guidelines by most society is that colon cancer screening should start around the age of 50.
Yeah.
Or at the age of 50 for most people. Now, if you have family history of certain cancers or colon cancer, then that could change when you need to start. So if the general guideline is to start 10 years before a first-degree relative was diagnosed with cancer. So if your mother or father were diagnosed with colon cancer, let's say at the age of 55, then you should start your colon cancer program, a colon cancer screening program at the age of 45. These are in general the guidelines. For most people, if you remember that when you turn 50, you need to start your colon cancer screening and discuss what options you have for screening. That would be a good thing to remember.
Yeah. And then based on the findings of that first colonoscopy will point in the direction of when to have the next one.
Correct.
Yeah.
And so typically when people turn 50 and during they get their physical, which is a preventative exam done by their primary care physician, then the primary care physician recommends some modality for colon cancer screening, which colonoscopy is one modality.
Yeah. So what are the other modalities?
So other modalities include stool testing, and there are different types of stool tests. They typically require either a small sample of stool or the bowel movement to be sent to a lab for analysis. And so these can be looking for blood, or they can be looking for mutations, doing some gene analysis on the stool to determine if you do have a polyp or if you do have an early cancer. And these would be needed to be done at different intervals than colonoscopy. There's something called virtual colonoscopy, which is an imaging modality. Basically, a CAT scan is used. You take a prep similar to the prep that is taken for the colonoscopy, or there are emerging tools where you don't have to take the same prep, and then you undergo a CT scan. And that CT scan with the software reconstructs an image of the colon, and it can show certain polyps. All these tests are called cancer detection test or polyp detection test. If these tests come back abnormal, then you have to have a colonoscopy to remove the polyp. There's also something on the horizon that's a capsule that you swallow, and it takes pictures of your colon, again, after you take a prep. And then if a polyp is seen, then you undergo a colonoscopy. So because colonoscopy is currently the only test that removes these polyps, it is the prevention tool. So if you do a screening test and you find a polyp, then if the screening test was not a colonoscopy, then the next step is to get a colonoscopy and remove that polyp.
So why haven't these other tools become like standard?
So some of them are newer, like the DNA test in the colon, or a combined DNA or blood test.
When you say DNA, you mean the stool test?
A stool test.
Okay.
And the currently available stool tests for human blood and mutations. And if it is abnormal, then you need to get a colonoscopy. So partly some of these are newer. So when they're newer, there are less studies on them than there are, let's say, on colonoscopy, which makes it gives the patient some unanswered questions. So for example, if you have a stool test that comes back abnormal, and you get your colonoscopy, and your colonoscopy is normal, what does that mean? Does it mean that cancer or an advanced polyp was missed on the colonoscopy? Or it means that the test showed what we call a false positive. So it told you that there's something that's concerning, but in reality there isn't. Because there's some uncertainty there, it causes some anxiety to both the provider, the person who's doing your colonoscopy, and to the patient. So some of these questions are unanswered, and they could limit the acceptance of these tests. Virtual colonoscopy has been out for a long period of time.
So virtual colonoscopy is, again, you take the prep and you get a CT, but nothing is inserted into the rectum.
Correct.
Right.
So the risk from this procedure itself is very minimal
Yeah.
because there's no sedation involved, and it's an X-ray modality. So you're not undergoing a procedure where you have a risk of bleeding or a risk of a tear, which can lead to surgery. But at the same time, it has different risks inherent to it. Like, so for flat polyps that are not protruding into the lumen, the miss rate is a little higher
Yeah.
with the virtual colonoscopy. There's also radiation involved, and we know radiation can increase your risk of cancer, and the quantification of that risk is not absolutely scientific. There's also risk of finding things that are not necessarily going to be relevant. So because it's a CT scan, they also get images of the kidneys, they get images of other things where sometimes it could be positive because they could find some other cancer that you were not looking for. But sometimes it could be negative because they could find something that is not necessarily relevant, wasn't going to affect your life, but now you undergo some invasive test like getting a biopsy to figure out that this was not important.
So we could find zebras, basically.
You could find zebras, and these could lead to other procedures that have risks. So even though on the surface it looks like it's less risky than a standard colonoscopy, it has other risks inherent to it, and that's why that's one of many reasons why it didn't end up catching on. Also, probably 25 to 50% of people have polyps.
Yeah.
So you're going to tell them you're going to undergo a test where 1/4 to half of the time is going to lead to you getting a colonoscopy.
Anyway. So these non-invasive tests, basically, if they find anything suspicious, you're still going to need a colonoscopy.
You're still going to need a colonoscopy. If the suspicion after the test is for cancer, you're going to need a colonoscopy to confirm it, to undergo the appropriate surgery. And if it's a polyp, you're going to need the colonoscopy to remove the polyp.
All right. Well, thank you for that information. I'm sure people will find that helpful, and I know I did. So that's it for the current episode. We're going to keep filming and talk more about Dr. Kachaamy's day-to-day work, so I hope you tune in next time.
Yeah, thank you for having me.
Sure.